Robuster. Hot news off the press. The next time you see me, I'll be Mrs. Barham, who I'm getting married on Saturday. So just to share some good news with you all. Leanne, could you just do mute for people on the call, please? Oh, thank you. That's so kind of you. So just some housekeeping. Please make sure you've got mute on. If not, Leanne will kindly mute you, just so we've got no background sounds. We are circulating the recording afterwards, and those who might need CC captions, you can turn that on at the bottom of your screen. And Leanne's going to be monitoring the chat function. Sorry, we had Yo-Yo the last time. So if you've got any questions, then please drop them into the chat function, and we'll use that throughout the morning session. I'm fairly certain most of you have been on one of our calls before, but just to remind you, the Health Innovation Network, we're one of 15 across the country, formerly known as the Academic Health Science Network. We were established in 2013 for, on behalf of NHS England, and we really look at innovation. One of the things that's really important to me is it's great to do innovation, it's great to do digital, but we have to make sure that we don't leave anybody behind. And the Inclusion Forum has been established for 4 years now to really try and share that best practice. But in addition to that, we connect NHS innovators, local authorities, and we've got voluntary sector who contribute to this as well. And we look after patient safety, improving the whole of North East North Cumbria's health, as well as looking into how we generate economic growth. So that's just a little bit about us. So today I'm absolutely delighted that we've got a great lineup of speakers for this session. We have gone for an alternative approach of asking some of our members to come in along and share their stories. So we've got Joanne Hall with Shafi from County Durham and Darlington and Medtronic. We've then got we've got Daniel Henderson, Regional Sales Manager for Exxon Health. So she's going to tell you about one of the things they do and how that's linked to digital inclusion. We've got the wonderful Julie Nicholson, who I know many will know from Digital Voice for Communities, and she's going to talk a little bit about the NHS app, amongst a couple of other things. And the wonderful Sarah Wilson, who's this will be our third time we were working out, coming back to just share her findings from her PhD. So I'm absolutely delighted that she's going to join us. So we're going to go first with Danielle. I'm going to stop sharing my screen and we're passing over to Danielle with her technology. Hopefully that will work.
Yep, hopefully. I'm just going to, I had a brief mouse problem before, so I'm just going to try and address this now. Sorry, 2 ticks. I am having a problem. I beg your pardon. Just 1 second, please.
That's okay. We know often live things don't quite go to plan, but we've always got backups for everything.
Yeah, I'm sorry, but my screen notes have disappeared. May I just stop and restart? Would that be all right?
Yeah.
So sorry about that. Let me try again.
Don't worry.
Oh, sorry, I've completely lost my my ability to use my script. So here's what I'm going to do. I'm going to try and deliver this presentation without my script then. So wish me luck. Sorry, and now that's completely...
That's what we have to do, just be spontaneous and react.
I will absolutely do that. 1 second, please. I'm so sorry. I'm just having a problem with my keyboard now as well. Oh dear. I apologize. Would you like to go change the order of speaking, and I'll come back to you momentarily. So sorry about that.
No problems. So, Joanne, could I ask that you take the mantle next, please?
That's absolutely fine, and I do not have a script, so I think we're just going off experience and memory. So let's hope the menopausal memory doesn't let me down. Can you see my screen?
We sure can. So you
sure can. Okay,
yeah,
okay. Okay, so thank you everybody, and thank you for giving me this opportunity to talk this afternoon. You can tell I've got a very strong Northeast accent, so I'm presenting in my own region, which is wonderful, so thank you for that. I currently work for Medtronic, and my job is to work with hospitals and ICBs and the HINs across the country on developing new innovations that help us be more innovative, to work in a more efficient way, and most importantly, provide the best care possible for our patients. So I'm a registered nurse, and I previously worked 17 years in one of the Northeast hospitals. So today I want to bring to you some information about a digital tool that we developed. So it's been in the workings for the last 2 years, and it's a digital tool that is specifically used for the management of type 1 diabetes. So I think I'm in the right place at the right time to talk about the digital landscape. So as we struggle in the NHS to cope with capacity and demands, we really have to embrace digital technology. So I'm a girl of the 90s. I didn't have a phone in the 90s, but I absolutely love a bit of digital technology that helps us get from Monday to Friday. So I worked very closely with a wonderful trust in our locality, which we'll talk about a bit more in a second, to develop a digital triage system for hybrid closed loop pumps. And it sits absolutely in line with all the focuses from NHSA, the Department of Health, the HIN, and our data execution for reshaping health and preventative health care, and really looking for the best outcomes we can get for our patients. So a little bit about Medtronic. You can see on the right hand side is the products that Medtronic really focus on to work with hospitals to support patients to be onboarded on. But that's not what we're here to talk about today. We're here to talk about the service that we have given to one trust, two hospitals within the region around these products. So just down here on the right hand side, you see the 780G, which is a hybrid closed loop system. So hybrid closed loop systems for the management of type 1 diabetes is absolutely at the forefront. And there was a technology appraisal that was approved in December 2023. Now, the efforts to put patients on these systems can be quite challenging. And sometimes putting patients on the systems is the easy bit. Monitoring and maintaining the care and support for those patients going forward to make sure that we give the focused care for our patients is probably the hardest part. We do have alternative systems, and these are included in the digital assessment of the tool that I'm about to show you. So we really focus really hard on providing systems outside of only product, and that's something I'm really passionate with. After spending 17 years in the NHS, I know how hard it is for people, and I know how hard it is to deal with the demands. So we developed a system called CareLink Premium. So CareLink is a software system that enables the healthcare professionals to triage, look at health outcome trends, and communicate with their patients remotely. Predominantly those patients with type 1 diabetes who are on a hybrid closed loop or a smart MDI system. The absolute focus of the development of this system was in line with the 10-year plan. And I'm sure we've all seen the 10-year plan, or we've heard bits about it. And the focus is that home, we prevent and we embrace the digital care. So every aspect of the solution is focusing and aligning to the 10-year plan. So as we talk about the three components and how they help the trust, I'm really fortunate that today at the end of the presentation, which will take about another 5-6 minutes, we will have Dr. Comerudden, who will give a really authentic evaluation of the system and his experiences to date. So the system itself has three main components. Number one is the triage, and that's where we can really triage our patients to their care need. So those who need the care the most, those who are struggling with their diabetes outcomes, that they're highlighted and they receive the care and they're highlighted to the HCP. Without such a system, all hybrid closed loop software devices are a bit of a snowstorm, so it can be often really quite difficult to find that information. So with the triage, the healthcare professional can sit down in front of their monitor and they can look and direct their focus to the patients of the greatest need at that time. The trust that I've worked with, County Durham and Darlington, have a very large number of patients on hybrid closed loop, offering a variety of insulin pumps, but with a very large number of Medtronic. And this enables them, most importantly, time to give directed care to patients in other areas of the diabetes service, because it's been an easier way to triage and assess the patients. As we focus really strongly on outcomes with the 10-year plan and population health management, we can look at trend analysis in the actual system. And the trend analysis covers a whole half a year, so 6 months data. And this is where the HCP can sit in front of the trends analysis and look, is the patient stabilising? Is the patient getting worse? Is the patient getting better? Where have they been? Where have they gone? So they have a clear upfront direction. They don't have to then check different electronic medical record systems to see what is happening to that patient. All the information is in one place at that time. And something which is really being embraced is the communication side as well. All areas have been embraced, but the communication side also. So from the communication, this is really helping with that remote communication. When the patient doesn't want to come in face to face, maybe they can't afford the bus fare, maybe they can't afford the petrol, maybe they want to speak to their clinician remotely. So the clinician can send the communication straight from the system to the patient's email, and they will receive information. There's lots of details that the physician can attach, so the patient feels informed and they can receive any information they require via this route. This is particularly useful when trying to manage large numbers of patients and really be proactive in care delivery. The last part of the dashboard is we focus on an additional outcomes analysis. So not only does the system triage patients to care need, give you a population health trend analysis, help you to be able to communicate with your patient remotely, but it also helps you analyse your patient outcomes. So this is for the total cohort, so the total number of patients within that trust delivery. The outcomes are then viewed, and I always remember as a young nurse, clinicians spending a lot of time on data outcomes, being locked in a cupboard for weeks and weeks looking at data. This happens automatically. So from a capacity point of view, clinicians can pull the data and they can look at how their total cohort is doing on this system. So it identifies their glycemic control, so their glucose control, and also their hypoprotection. And this is very important to prevent admissions and touch points or visits to A&E, all of those kind of things. so they can really look at the data and analyse. And also the hospital can analyse their data there and then, and also create snapshots, as many snapshots as they want. So that's the outcome data as well. These guys are the superstars. So these are the guys who have partnered with Medtronic to deliver this triage service. They have embraced it with their service. So there's Dr. Abigaila at University Hospital of North Durham and Dr. Shafi Kamarudin at Darlington. And the whole team have been involved, and Dr. Kamarudin did bring together the whole team, dietitians, nurses, so everyone feels informed and included, that when they're using this system, the system is efficient and helping them to deal with the capacity that the hospital is seeing. And before I pass on to Dr. Kamarudin, I'll show you some of the quotes from a survey that we did with Durham and Darlington Hospital. And I think one of the great things, number one, it's easy to use. Everyone wants something that's easy to use. But to give that support to the nurses, clinicians and dietitians who are trying their hardest to deliver the healthcare for hybrid closed loops. And to, you know, in the middle there, we've got a pivotal to risk stratification, that, you know, we identify in patients when we need to, that they're able to focus on patients who need the priority, that they're feeling efficient and they've got a tool that's easy to use and it's user friendly. And I think that's really important when we're developing digital solutions with hospitals that we work with across the country. So I hope that's given you some insight. I'll stop sharing and let Dr. Kamarudin take the floor to explain how he has felt the system has helped or enhanced his service. Are you there? Come on. Are you there, Shafi?
Hear me, yeah?
You're there.
Can you hear me, yeah?
Yeah.
Perfect. Okay, so what I'll try to do is to contextualize what Joanna's really explained to us. So if you think about County Durham and Darlington, we've got probably about 40 to 50,000 patients with diabetes, of which estimating about 10% would be type 1 diabetic patients. We're talking about 4,000 to 5,000 patients that we are responsible for with type 1 diabetes. And the majority of them are on some form of technology. And the technology I'm specifically talking about is obviously what we call hybrid closed loop system, where it's an insulin delivery system which talks in real time to a sensor device that checks the glucose in real time. But what it does also, it feeds up that data in real time to the cloud system. And we as healthcare professionals can see the data in real time on our end, really. So in CDDFT, which includes Durham and Darlington, we've got about slightly more than 1,200 patients now on hybrid closed loop systems. But on top of that, we also have what we call the smart MDI. These are smart pens, again, linked up to the sensor. Again, the data is being transmitted in real time through the cloud, and we can see this data. So we're very data rich, and the danger is that when you've got a limited workforce, you get really overwhelmed in how you're going to manage these patients. There's a real patient safety and governance issue from a healthcare professional point of view. So the system that Medtronic has come about really is to allow us to, identify patients who needs our attention. So it's using a traffic light system. We set the parameters. Those patients who are not meeting, the anticipated target of their glucose control. And then my specialist team basically log on and prioritize patients who are, let's say, in the amber and the red group, leaving behind the green group to carry on, because these are automated systems are there to keep the patient safe. So that in itself allows us really to, balance our demand and capacity, because we only got limited specialist staff to manage such a huge cohort of patients. And I have to say, we are one of the early adopters of technology, diabetes technology in the country. In fact, we were part of the pilot group for the NICE guidelines as funded by NHS England. So huge numbers of patients, and that created a lot of anxiety for the clinical team, but with such a system, a software, we're able to triage our day-to-day workforce to meet the demands of a patient that needs our attention. Obviously, the second bit really is the fact that there's an ability to audit our service. So if we've got 1,200 patients on such a system, we need value for money. So and also we've got a responsibility to make sure that, for those patients who are not meeting the target being on such a high-tech device, we need to work with them and help them and get them back on track. And the final bit is obviously it is also a means of communicating with the patient digitally, although we do have other systems in place as well in CDDF to liaise with the patient. So all in all, I would say that it's a great system. There was a bit of anxiety adopting in the beginning, but it's actually helped us in a lot of ways. As Joanne alluded to, I'm a stickler for offering patients options. There are many types of hybrid closed loop system, but Medtronic is our biggest partner. And my question is to the other providers, why are they not doing what Medtronic is doing really? So that's my, take from a real world experience from a clinical context. Hopefully that'll give you an idea what the system can offer really. Are you happy with that, Joanne? It's just a very brief mention from a clinical point of view.
Absolutely, thanks, Shafi. And I think is just to give a nurse an perspective as well, is that the nurse and team are under constant pressure every day, and to have the system to go in and just to fine tune and assess the patients in a quicker fashion is allowing them to dedicate time to areas where there's other pressures. So they never sit back and go and have a lunch for a couple of hours, unfortunately, but it does provide them capacity to look at other things. And sometimes it is other software that's maybe not quite as lean, but it really is a great tool from the point of capacity management, but also looking at that population health management. And the nurses that work with Shafi are extremely experienced and interested in making sure that the outcomes that the patients are getting are the best, and we see that in the data that they're collecting. Thank you, everybody.
Well, thank you very much, Joanne and Shafi. We've got a couple of questions from the audience, but I've got a couple for myself as well. So you've given that perspective around efficiency, the staff love it, it's absolutely brilliant. What about the patient? Is it just more that the technology that you give them connects with a phone, and do they need any training or any support to be able to use that?
So the patients are already signed up for something called CareLink Personal, which is the patient aspect of the downloading system. So the patients are trained to look at their own download reports themselves, and they can make them personalised to themselves. This system was specifically looking at a capacity management digital evolution from the hospital side. So the patient has nothing else to do, but the patient will have that inclusion by receiving the communication directly from the HCP to their email address. We're in constant development. You've reminded me, thank you, Rachel, for reminding me on this side. We're in constant development in the interoperability journey as well, and we will work with the trust on this as well. But what that means is the system as it is now, it's constantly evolving. So I actively encourage both the patients and the HCPs to feedback. And we have other apps that the patient use with Medtronic, and it may be that we'll embed this system into that patient app. So it's kind of watch this space with this.
Exciting.
Thank you.
One of my other ones, and one of the questions from our audience was about AI as well. And, have you got any AI embedded in it? Is there any plans to? Do you see it adding any value to the inclusion side of things to help support patients?
Yeah. So we have to be careful. This is where the nursey bit comes out of me. So we have to be careful that so the system is triaging patients against international consensus parameters. So agreed parameters that everybody agrees on. But at this time, we can't fully replace Shafi, and not yet anyway. But we need that clinical experience and interpretation to almost manage the system. So it will be continuously developed, and there will be further AI developments. But at this time, it is part HCP, part digitally driven. And Shafin, I can see you're going to say something there.
Yeah.
Yeah, so I would probably be careful about the utility of the term AI. There's a lot of meaning to it. So the system that we're talking about is pretty much an algorithmic-based system. So you have some certain parameters. If you stray away from those parameters, then it triggers, a triage system really. And that's simply what it is. It is obviously very complex. I don't think we can get rid of healthcare professionals. If you think about diabetes, it is not just about the blood sugar. There's a whole variety of things that you need to look at. So I don't think AI, I'm not concerned about losing our jobs really. I mean, but what I would say is that AI will definitely be beneficial when we have complex data coming in and you're looking at trend recognition and then basically facilitating the ongoing care by either highlighting or making some minor tweaks here and there. But remember, there are many more subjective parameters that we cannot objectivize that requires healthcare professionals to be able to.
It'll never replace our wonderful NHS teams. Absolutely not. So I've got two little final questions to finish off with. So did it take much training for the patients to be able to use that smart pen, or do you find that it's quite easy to use?
Don't mind, because I've been working with Joanne for many years, and many of the other companies. I'm very particular about onboarding, and what do I mean by that? It's very easy to dispense technology to patients. These are very expensive devices at the expense of taxpayers' money. So we have a very clear plan. When we decide to put someone on any technology, at least in my trust, we have a very clear onboarding process, and they really have to follow. They have to take time off. They have to follow and this, follow-ups and so on. And I have to, compliment Medtronic. Medtronic's particularly good at the onboarding process. We have a very clear framework on what to do when they go on to, a hybrid closed loop system, which is more complicated, or your smart MDI pen. So we don't really, we don't do it on an ad hoc basis. It is very much, we can do it in person, we can do it virtually. We've done it enough times virtually that we've got enough experience, and COVID has taught us how to do that. So, but it is a very clear process to reassure everyone. So it's not something that we take it lightly. In the past, many years ago, when I first started doing this, 16, 17 years ago, it was very much ad hoc. We were happy to dispense, but we were not good at following it through. So we were not getting value for money. But I'm very clear about the onboarding process. I would hope that many of my neighboring trusts or other units will be doing the same thing as well. Hopefully I'll reassure everyone.
Yeah. I think just to reassure whoever if that person was a patient, I attended a group which one of Shafi's nurses ran, and it was very, we had a great time. We had a cup of tea, we had some biscuits, we had the system of the smart MDI in front of us. And, the patients followed the specific training pathway of onboarding with a lovely nurse called Ashley. And it was all very simple and relaxed. But like Shafi says, it's formal, but it's made informal, because that's really important.
And it's so essential that we give the skills to patients. We can't just assume everybody has access to digital or the means or the skills. So that's really important for us. My final question kind of touches on one of the characteristics, is around maybe it's visual impairment. How does this type of technology support somebody who's maybe blind, and how would they use that technology?
Joanne, because I've got a few patients who are partially sighted. I just don't want us to get confused between what we are trying to showcase here, which is a software that allows us to triage and look at trends. But if you're referring to the technology itself, what we call the hybrid closed loop system, so it is an insulin delivery system, or simply put, it's a pump. You've got a glucose sensor that checks the glucose 5 to 10 minutes. Every 5 minutes, you get 200 plus readings a day, but it talks to each other. So it's quite autonomous in terms of how it manages your real-time flux in your glucose. I have quite a few patients who are partially sighted who are on such system. The key thing is, again, it comes back to the onboarding program where we start them on it. So we spend a bit of time, we make sure there's safety net in, we make sure that they've got easy access to healthcare professionals, and so on and so on. So just because you're partially sighted, there's no reason why you cannot go onto such system. I have a twin sister who's completely blind on it, and they manage very well. So we push all the boundaries. I've got few patients with learning difficulties and so on. There's no reason why not to try. So we do push the boundaries, but we make sure it's safe as well. Yeah.
Well, that was brilliant. Well, thank you so much, guys. Do please stay. We've got some great further speakers lined up. If you've got capacity to stay, that's great. We will share the PDF slides for everybody to see afterwards, and reach out if you've got any questions or particularly interested. But it's great to see kind of forward thinking around that digital option as well, because it's an enabler to so many things, and particularly for me about improving patient safety and care. So that's really, really refreshing to hear today. So thank you for your time. Oh,
Thank you.
thank you. Danielle, how are we
Yes.
doing? Are you with us? Would you like to share your screens, and we'll
I'm
see how we get
hoping-
on today?
I'm hoping you can hear me okay this time. And can you hear me all right?
Yes, I can hear you fine.
That's
Loud and
wonderful.
clear.
I'm just going to try sharing my screen. So I've come back on a different laptop. So how is that looking?
Yep, that looks great.
Wonderful. I'll make a start then. Thank you so much. Welcome to my part of the agenda. I'm Danielle Henderson, Regional Sales Manager at Exon Health, and I've been looking after the North East and North Cumbria ICB region since 2016. We offer a suite of solutions that make up an intelligent care navigation system comprising of patient-centric solutions that enable the patient to choose how they access care, along with tools that improve operational efficiency within the GP practice environment. You might already use or have heard of our Surgery Connect phone system, which is installed at 3,500 GP practices, making us the leading advanced telephony provider for surgeries. And it's interesting to note, actually, that on a Monday morning, our systems handle over 5 million patient calls. 110 of those surgeries are actually in your ICB. In addition to the telephony, we also provide Surgery Intellect and Ambient Scribe, which can be used for outbound calls and face-to-face consultations, Surgery Assist, our digital support assistant or chatbot, and Surgery Insights, our dashboard, which brings data for all of these things together in a single place. My presentation today is going to take around 10 minutes, probably less, and there'll be an opportunity for you to ask questions at the end. So this diagram is designed to show you how each of our products fits in with the modern general practice model. And you can see here how Surgery Connect fits in, providing an important tool for contacting the practice by phone. Then Surgery Assist will intercept and act as a filter, chatting with patients so that many who don't mind using apps to carry out tasks such as ordering repeat prescriptions and managing appointments and self-referring to local and national services can do so without ever having to speak to a member of the team. And what that does is leave the queue for the phones much smaller. The Intellect product, the Ambient Scribe, uses AI intelligence to listen in to outbound calls to patients and also during face-to-face consultations, leaving clinicians to spend more time focusing on the patient without having to type into a keyboard whilst trying to listen to them. The technology summarises the consultation for the clinician to check over before submitting to the clinical record. It structures the output, turning natural dialogue into clinical codes, SNOMED codes and summaries, and we think saving on average 4 minutes per consultation and ensuring the patient feels more valued and heard. Voice agents are AI-based tools which allow the patient to speak naturally with Surgery Connect, the phone system, enabling them to navigate and begin and complete tasks even using just their voice. And then finally, Insights, bringing everything together to help individual practices to see the whole picture of demand and what the emerging patterns are. The dashboard provides a comparison for a surgery against national benchmarks. And with all these digital tools being utilised by the patients who prefer them, those patients that are now digitally excluded for whatever reason can get through simply and quickly to speak to a member of the team. So how do all of these help to address key digital inclusion barriers? Let's start with accessibility and usability. Firstly, all the products are built with a focus on ease of use. This is crucial for patients who may not be highly tech savvy or confident with digital tools. All patient interfaces are designed to be user-friendly, reducing the need for an extensive set of digital skills. Surgery Assist provides multilingual support in the form of dynamic translation in over 60 languages. This directly addresses the needs of patients for whom language is a significant barrier, ensuring that they can access information and services in a way that's understandable to them. Responses to questions asked by Surgery Assist are delivered back to the patient in the language in which they ask them in a matter of seconds. Thirdly, in terms of routes into the practice, we offer voice access via Surgery Connect the phone system, yes, of course, but also Surgery Assist offers an alternative way to communicate by chat, giving patients the chance and the choice to communicate in a way that's most comfortable for them. And this, of course, might be outside of regular surgery opening hours, which brings a further advantage because patients can get support for services straight away, regardless of the time of day. And regarding accessibility, all services are WCAG 2.1 compliant with an AA rating, offering inbuilt accessibility tools such as text sizing, grayscale, and so on, thus ensuring that our products are available to as many patients as possible. And full copies of each individual's product's equality impact assessment are available upon request. The next barrier we address is that of a patient's access to technology and to data. Firstly, the Surgery Connect callback feature is particularly beneficial for those with limited phone credit. They don't need a complicated smartphone to be able to use this feature. They only need to be able to generate a tone on their keypad to request to be called back when their position reaches the front of the queue. Patient callback eliminates the need for patients, therefore, to wait on hold, saving them money and reducing frustration. Exon's callback mechanism is quite sophisticated in as much as if they don't answer the first time, then the system can be programmed to try a number of times to maximise the chance of success in conversation. Next, let's consider the use of text or SMS from a staff desktop PC to a patient's mobile phone. By using our simple outbound SMS function to communicate basic messaging from Exon's phone bar software, individual patients can receive important information in a really simple text format if they don't have a smartphone or if they don't have internet access. Finally, if no option is selected by a patient phoning into a Surgery Connect phone system because perhaps they are unable to use their keypad or maybe they feel overwhelmed by all those menu choices, then if they stay on the line, they will simply be put straight through to the team by default. The last barrier to consider is that of the burden on staff, inasmuch as their ability to manage the demand, which includes those patients who are digitally excluded for whatever reason. As we have said, Surgery Assist acts as a filter, intercepting anything and everything that comes into the practice for those that wish to use it. This in turn helps to reduce the administrative burden on practice staff. By signposting patients to the most appropriate service, whether that's an online form, a community service, an app, or online service, this actually frees up staff time. That then allows receptionists and care navigators to focus on helping those patients who have more complex needs, including those who find digital services simply overwhelming or out of reach. One feature in Surgery Connect's call flow management system is the ability to identify patients by their calling line identity or CLI, and place them in a group which then controls how they're routed through the system. So, for example, someone with a CLI that falls into a vulnerable group, let's say, they might be sent straight to the front of the queue, or perhaps to a particular staff member who is trained to deal with their specific difficulties. As that staff member then goes to answer the phone, they'll also be informed by Surgery Connect by way of a little message that plays into their ear to say there's a particular kind of call coming through, so they can be ready according to their training. Additionally, the phone bar software shows here, as you can see, that there'll be a pop-up message on screen when they answer showing who the patient is, which number they dialed, who they spoke to and when. And perhaps the most important thing here is that it can display the flag assigned to them by the system. Again, another opportunity for the staff member to be really ready to deal with that patient in a particular way. And then finally, I just want to say, by adding automation to the practice setup in all the ways described, then the Surgery Insights dashboard will allow ICBs and individual GP practices to consider the whole picture, not just patterns of patient demand, but also clear improvements to performance, showing how operations were made more efficient over time with all of these things. And speaking of the Surgery Insights dashboard, this is just a better view, a larger view, if you will, of all the different data points that are shown, that are reported on. Sorry, and all of Exon's products are appropriately certified with regular independent testing from outside sources to ensure that security is really robust. So hopefully I've shown you that Exon Health's products and solutions can significantly aid digital inclusion for patients in North East and North Cumbria ICB by bridging the gap between digital and non-digital access points. The ICB has obviously got a strong focus on digital inclusion, aiming to ensure that no one is left behind as more and more services become digitally enabled. Exon Health very much aligns with this strategy, first and foremost by just being aware of the need to bear the digital excluded in mind when developing and designing our products. Secondly, by providing flexible, user-friendly communication tools that cater to a diverse patient population, including those who may face barriers related to digital skills, access to technology or language. So you can find Exon Health and myself on LinkedIn. Please follow and connect with us. And if you want to know more, you can use this QR code. We have some very exciting products coming on our development roadmap. So I do recommend you follow us to ensure that you don't miss any developments. And I'll just take some questions if I may.
Fantastic. That was great, Danielle. I was interested in particular about the multilingual element of the system, because I guess it's probably using that modern, more diverse type of technology to be able to present it in 60 languages. How receptive are patients to hearing that? And does it do audio as well as a written format?
Okay, so at the time of speaking to you, it's just available in a textual format via Surgery Assist, the chatbot. And actually what it does is it notices and recognises the language that the query is being asked in, and then it goes away behind the scenes and actually puts it back into English, looks up a frequently asked questions or correct answers table, gets the answer, puts it back into the local language, and then gives it back to them. However, I mentioned to you at the beginning when we were looking at the modern general practice model that the voice agents are not far behind. So yes, the idea is to get all products up to speed so that you can then choose to either interact with your GP practice by text, but also by voice, and therefore the language would come into that as well. So, and therefore to ask the question in the local language. Yeah,
that's great, because I just know obviously sometimes even educational attainment in other countries isn't the same. So actually verbal, that audio is always one of the best options I've found. So that's fantastic. I want to ask about how have patients taken to it, using AI, transcribing something in front in a GP practice. What's the kind of feedback been around that?
It's all been very positive. And one of the main reasons I think that patients love things like Surgery Assist or chatbot, for example, is the ability for them to be able to use it 24 hours a day. So, and we have a great example. I don't know if you know Bridgeview Medical Practice. They're in the Sunderland area, and they have
a super, very well.
Yeah, wonderful. Well, they deployed Surgery Assist, the chatbot, a couple of months ago, and they had some great, really early findings in the form of some really clear return on investment examples shown by the admin time saved. So they actually were able to save a day per month in admin time just by filtering out those people that could be filtered. And my point of mentioning that is if you can get as many people referred away as possible, those that don't mind using digital tools, actually what you're doing is freeing up that capacity for those people that just need a more delicate touch. And I'm thinking particularly of those that are digitally excluded, just overwhelmed by systems generally. Let's actually give staff in the practice the ability to spend more time with them, take it slowly, and obviously handle them according to their training.
That's brilliant. Yeah, so I know for Bridgeview and their demographics are very challenged.
Absolutely.
So it's music to my ears to say that it's SMS. They probably don't need to have that credit on their phone, because that can be a massive challenge for some of those patient groups. But you're still being able to interact and get the optimum health for them. I think that's really true. Yeah, and we've got just a question from our wonderful patient rep, Violet Rook. How much training did you find that the GP staff needed in order for them to use all of the system?
Okay, so if we look at all the sort of different products, starting with Surgery Connect, the phone system, then the general feedback from both the sort of if we focus on the users rather than the sort of supervisors who would have a more detailed understanding, but as a GP or a reception staff member, people always say how very simple our phone bar software is to utilize. It just sits on the desktop, sits above the clinical system. So you either receive a call in and it shows you which patient it is, or you click to dial out. And of course, there's nothing more simple than clicking a button to dial a number rather than manually tapping the number out and perhaps getting it wrong. So that's Surgery Connect. Surgery Intellect, the ambient scribe, again, the feedback, that's a relatively new product, but the early feedback is it's super easy to use. It just sits on the desktop. It's a little brain. You just click it and then it listens in, and then that's super easy. It just listens, it filters out all the nonsense, and what you end up with is a summary set of notes, and that's going to save 4 minutes off every consultation. So again, the feedback is it's quite simple to use. And in terms of Surgery Assist, well, again, from a patient's perspective, it's really super easy to use, because Surgery Assist just asks them to either choose a button to choose which path they want to go down, or it just simply allows them to ask an open question. So that's a very simple experience from the patient's perspective. And again, from the staff's perspective, and Bridgeview hopefully will underline this, we're aware, of course, with all our experience being one of the main providers in general practice, about all the national resourcing. So that comes sort of pre-programmed. Then all we need to do at the individual practice level before they go live with their own Surgery Assist is actually ask them what the subtle nuances are, you know, the sort of local services that they would prefer to signpost callers to, inquirers to. And of course, the fun bit is that they actually get to design an avatar. In the case of Bridgeview, they actually based it on one of their reception team members. So when you go on Bridgeview's website, I'm sure they won't mind when you do, you'll see that Jess actually pops up.
Oh, I know Jess
It's
well,
brilliant.
so that's
You'll
good.
have to have a look. There you go.
I will
Does
do.
that answer
So
the question okay?
I'm sure it does. I'm going to ask one more question.
Please.
We've got a comment just more about kind of their practice doesn't use that type of technology.
Yeah.
I think there's their ambition, you know, the 10-year planning is quite wedded with the whole digital world as well. So I would expect to see improvements over a period of time. But the last question is about AI bot, and has it been past the healthcare regulations? So this is always, it's an unknown territory, but just if you've got any quick response to that, Danielle.
Yes, I mean, absolutely, that it's got all the accreditations it needs to have. Of course, we would have to have all the appropriate ones to be able to operate in this space. So the answer to that is yes, but I would just point out, in the case of Surgery Assist, the chatbot, it's not identifying any patients. It's giving answers to questions and signposting away without, you know, so from a sort of data point of view, it's not identifying who they are. So that may take away some of the concern there.
Brilliant. And there are other couple of questions. You might want to have a look in the chat and respond afterwards, but we're going to have to move on.
Thank you.
Final comment would be, it would be great to test it on the Mackem and Geordie accents of the North East,
no problem.
Cumbria as well, so which is always good. So we're going to move on to our next presentation. Thank you so much, Danielle. And we have got Julie Nicholson. So Julie, would you like to join us?
Hi, everyone. Hello, can you hear me?
Yeah, we can hear you. And I'm just checking, we have got Leanne sharing your slides today, is that right?
That's right, if you don't mind, Leanne.
Leanne?
Give me 1 sec, it is just trying to share now. So the PowerPoint side of it won't share, so let me just see if I can get it in a PDF version. Give me 1 sec.
Okay, apart from the video, it's very much just nice photos to illustrate what we're doing. I can just chat if you'd like.
Leanne, I'll share mine because I've got it ready.
Have you? Thank you.
Yeah, no problems at all.
That's great. So you want to go straight on to the next slide, please. So, hi everyone. So Digital Voice is a multi-award winning social enterprise. We're just in the process of becoming a charity, just so that we can help more people. And we do lots of different activities to do with digital inclusion. So we help people to make films, do photography, digital stories. If you go on to the next slide, please, Rachel, and I'll talk to you about our digital inclusion skills development. So very much in touch is about getting people online, learning how to stay safe, recognizing scams, doing their shopping, communicating with others, being able to look things up. And we've been doing that for many years now. And we usually do that in 6-week blocks. So 6 weeks of 2-hour sessions, and it's really fun and informal. We do it in the spaces where people already go. So we work with councils and housing associations to do it in community lounges or community centres, wherever people already go usually, so that they feel comfortable. And now if you go on to Tech Together, so this is what I want to talk to you about today. I'm sure many of you have heard me talking about our general digital inclusion work, but Tech Together is a pilot that was funded by the local ICB, the NENC, to see if what we thought was a strategy for those who are the furthest from being digitally included would get. So the difference is that we give people a device on long-term loan to combat device poverty. We give them data from the data bank so that they can go away with a device and practice the skills. Because we're finding that those who, for whom developing digital skills is really difficult in terms of retaining the information, or because of data poverty or whatever, some people by the end of that 6 weeks, if they didn't have a device at home, we're just forgetting. And obviously what we want is that the people who most need to be digitally included are. So Tech Together was our way of being able to test that. And if you go on to the next slide and play the video, I'll stop talking and you can just watch.
So, Julie, can I get you to share your video? You had your
All
YouTube
right.
button. Yeah, if that's all right. So I'll just stop sharing.
Absolutely.
Sorry, this is where we had some technical issues earlier.
Okay, can you hear that?
Yes.
Digital Voice helps people to develop their digital skills, which also helps them with their confidence and lots of other benefits. We do this in a really friendly, informal way so that people enjoy themselves while they're getting those skills. And usually they're 6-week courses where we help people to recognise scams, stay safe online, to communicate with others, fill in forms, look things up. And 6 weeks is usually long enough for a lot of people. But if those people have never used a device before, or more importantly, I think, not got access to a device or the internet, then those skills after that 6 weeks might go. So we started the Tech Together pilot as a way of trying to make sure that people who have fewer opportunities to get those skills can have longer time spent in the training. So we do the 6-week course, but in Tech Together, the people on that course then have 6 more weeks of one-to-one support. And more importantly, they get their own device and some free data. So we wanted in the Tech Together pilot to work with 2 of our priority groups, so older people and people with learning disabilities. So in Weardale, which is rural County Durham, we worked with a group of older people who are, because of where they live, very isolated. And in Teams, which is Urban Gateshead, we worked with some people were older and some people were adults with learning disabilities.
I'm Liz Foster. I wanted to come onto this course because in the near future, everybody will be online. And I feel that I need the confidence in getting used to laptops, iPads, whatever is easier for me. Being dyslexic, I find the iPad, the tablet easier to get going, to feel confident in myself. And the course so far has been I've really enjoyed it.
At the start of these courses, there was a fairly wide range of skills and ability and knowledge within the groups, but most of them were fairly low on the skills levels. So they were either, maybe some had used their phones for the odd thing, some didn't even have phones. So there was a real mix there. And within the learning disabled group that we've been working with, there was also a range of literacy skills. So some people couldn't read at all, which obviously makes operating a digital tablet a lot more difficult. And others could read quite fluently, and others were sort of in between. So that was a bit of a challenge that's different to most groups that we work with. And really, one of the great things about this course was we really were able to go into a bit more depth on accessibility, and also the accessibility features on some of these devices has improved recently thanks to the introduction of AI. So we were really able to focus on how AI could support people who had very low literacy levels, to help them to be able to, using screen readers to read what was on the screen.
Link, household waste and recycling centres.
And also helping them to use voice to text software so that they could talk in their commands.
Hi, Ronnie. How are you doing?
Here is the email. Another thing that's been slightly different while we're running this course is that we're really focused in on getting everyone signed up for and using the NHS app within the course. And that's been really successful. Everyone is now signed up and they're all using the app and finding some benefits, whether it's for people in Weardale who had quite a way to go to the surgery just to put in a repeat prescription. Now they can do that from the app. So that's been really useful for all the client groups we're working with.
What happens with my anxiety? Everybody was helpful and enjoyed meeting new people, and I'll definitely do it again. I'll do it again, definitely.
So yeah, you saw there that we've started to help people to use the NHS app, and you can see the impact there, I hope, on people. It was so useful. So I'd like to just lead on to the next slide, if that's all right, Rachel, and talk about the NHS app work that we've been doing in Gateshead. So we have been lucky enough to get a contract from a PCN in Gateshead. So we've been doing NHS app direct work in surgeries with patients. So going into the surgeries, using really friendly approach. So, you know, asking people to come back if they were in a hurry, but we've been overwhelmed by the how useful it's been for so many people. So if you want to go to the next slide. So it's really friendly. We've got a team of 5 experts who go in there and using the devices that we've bought for the surgeries, helping people to get online. And there's so many different things that can go wrong for people when they're trying to do that. So we've learned along the way loads of different stuff. That's been really helpful. So next slide, please. So we've got loads of different like promotion that we use, put it on social media to get people to know that they can come into the practice, and that we can help them with that. And they can do so much. It depends on the surgery, obviously, but they can do so much in the app that a lot of people didn't know about. A lot of people didn't know about the app. So I think it was really forward thinking of that PCN to do this work and to get so many people on using the app, because obviously it's win-win. It's great for the patients, but also saves time in practice, and we all know how overstretched surgeries are. We've also been training the staff, if you want to go on to the next slide. So training staff in each of the surgeries. We did some consultation with them all, and then we've gone gone in and done some one-to-one with 2 of the reception staff who are going to carry this work on. So we've been there for a few months now, but the great thing is that they've got the devices set up, and they're going to keep on doing that. So keep getting people onto the app. We've also just done a one-off session now with Alessandra. I can't see her in the thing, but Alessandra from Connected Voice has been really helpful to make connections between us and organisations which want to get their service users more digitally included and onto the app. So we did a session just recently with Hope Beyond Borders, with People Seeking Sanctuary, and it was really interesting to see how we can make those AI functions work with different languages as well. And we are, if you go on to the next slide, going to offer some CPD. So do get in touch. It's going to be in Get Online Week, which is week beginning in October, the 20th to the 25th. It'll be on one of those afternoons, probably with myself, Alessandra, our NHS app team, and hopefully somebody from the NHS, from that PCN. And if you go on the next one, that's my contact if you're interested in coming along. So it's going to be very much learning from the things that we've had to learn along the way when we've got stuck, how we've sorted that out for people, the things that you might not already know about using the NH app with people from different, with whatever reason there was that something's gone wrong. If, for example, if you come from another country, then it can be quite complex getting people onto the app in terms of their ID and things like that. So it's basically a troubleshooting guide from us, and we'd love it if you could come along. So do take my email and get in touch if you'd like to do that. We will promote it and hopefully ask others in the call to promote it for us. Any questions?
We do have a few questions, Julie. That was fantastic, and I'm always a big ambassador of the NHS app. So it's great to see some of that fantastic work going on. One of the questions somebody's asked about whether or not this is done in the Cumbria area. I'm not sure you use Extend over that far, do you?
We do. We work with Cumberland Council, for example, so we do go over to Cumbria. So we'd be happy to do this wherever, really. We could maybe train up people over there, but we do have people that kind of live in the middle. So yes, we could do that there if you wanted to get in touch.
Fantastic. So we're going to, or how do we make a case, they're asking as well. So you probably can give them some insight into how to pull a business case together to do that, which is great.
Yeah, get in touch, I can help you.
So it's a little bit about the equipment. So you loan that equipment to somebody. Where do you get your equipment from? Did you put a bid in? Did you buy them yourselves?
Yeah, so it was the NENCICB which funded that pilot.
Yeah.
I don't know if Tony's in the call.
I'm not sure today. I've got
so thanks to Tony and her team from the NENC for funding that, and it did make such a difference. Like, we've been working with people for a long time doing those 6-week courses, and it does break my heart if people don't have a device. So this was just a test to be able to prove that if people do have a device, then they can just fly with it. And each of those one-to-one sessions were like building people's skills and things that they want to do as well. So it's, what might you use it for? What are your interests? What do you want to learn? So it's really bespoke to them by the end of the 12 weeks that we have with them.
Brilliant. And how do you wipe? So as they return that device to you, how do you wipe that so that it's obviously got no personal information on for each of the clients?
They're not returning them.
Are they not? So you're just kind of gifting them? Or
so it's a long-term loan for 3 years. But after 3 years, nobody's going to chase them for it. I'm certainly not. So we would really like to be able to give people those. It's so hard to get funding for that, though.
Yeah,
but I do think that it. Loan schemes are great. Don't get me wrong. It's something, isn't it? But I think it's the cherry on the cake to be able to give someone a device. And I think we even had, luckily, some data that was like 2-year bank data SIMs as well for some people. Obviously, it's a look. I don't know if any of you used the data bank, but it's luck of the draw what you get. But we were so lucky that at the time we were doing these, some of the SIMs that we got were like 2 years worth of data, so that's brilliant.
Oh, brilliant, because that was one of my other questions, but you've mentioned the data, so that's fine. So we have got a very long question, but I think it's more from a research point of view. So I'm going to ask Leanne just to connect on email so that you can answer that. And you'll probably be able to find a bit more information as to how many people you helped in a particular year and what about 18 to 27-year-olds, etc. So there'll just be some really useful information that you can share if that's all right.
And we work with people of all ages.
Brilliant, and we will move on. So thank you very much. Sorry, I just loved in the video about using AI for low literacy levels as well. I thought that was a really, we're seeing that technology and people being very creative with how they can maximize its use to really help people. And I think that's really supporting that inclusion, not just about digital, but we're using digital to include people in those services. I think that's fantastic. Brilliant. Well, thank you very much, Julie. Do stay on. You might want to jot a couple of responses in the chat as we go. And we're moving on to our final presenter, the very patient and very lovely Sarah Wilson. So Sarah, the floor is yours.
Thank you very much. I'll just share my screen. Cool. And then can everyone see this?
Yes, I certainly can.
Amazing, cool. So as mentioned, I'm Sarah Wilson. I'm a research assistant and PhD student at Newcastle University. And this presentation is just going to summarise the findings that I've developed from my PhD project. And I'm going to really focus on the recommendations that I put together from all the bits and pieces of work that I've done. So the PhD used a multi-methods approach. So it used a scoping review, a systematic review, 2 qualitative studies, and also just sort of like looking at everything holistically as well. So the reason why I took that approach instead of just like focusing on one method of doing a bit of research is to make sure I have like loads of different perspectives from people, to make sure I do have that holistic understanding of not only digital exclusion within healthcare, but also to help us develop some new insights on how we can advance digital health equity and how we can move things forward in a way that's appropriate for everyone. So the first thing I wanted to do was to do a scoping review. And this was done because there was no other health inequities framework out there that specifically focused on health inequities, on digital exclusion even. So you have like the Progress Plus framework, which looks at digital health inequities in general, but nothing that focuses on health, on digital exclusion even. So after I looked at 22 articles, there was 6 groups that kept on coming across all these articles, and these groups just identified those who are most at risk of digital exclusion within healthcare. So things around the cultural factors, we have ethnicity, language and religion. Under limit conditions, we specifically have those who with visual and hearing impairments. We have low educational attainment, so like GCSE level and below. We have age, so particularly those over 65 years old are more likely to be digitally excluded. We have those who live in rural or deprived areas or homeless or don't have a permanent residence. And we also have those on a low socioeconomic status. And then this black line that sort of connects all these groups together, that just represents intersectionality, which just means if someone is a part of 2 or more of these groups, they're at even greater risk of digital exclusion within healthcare. There we go. Now that I understood who was most at risk, I then went out to identify the different strategies that are currently being used to promote their inclusion within healthcare. So to do this, I've done a systematic review, and I end up systematically reviewing over 10,000 articles, and then from that, only 10 of the articles met my inclusion criteria, and I was specifically focused on qualitative studies that were looking at people's perspectives of using a certain strategy. And I was particularly focused on these kind of type of studies, so I could really understand the different factors that play a role in why something does and doesn't work from the perspective of those who are actually most important and those who are using these strategies. So in this case, it was the underserved groups and those most at risk of digital exclusion. And then from these 10 articles, I then identified 3 overarching themes, and these themes just described the facilitators and the barriers and the challenges around using a user-friendly design, having like a supportive infrastructure there. So by this I mean sort of providing devices, providing connectivity, and things along those kind of lines. And then the last one was around the importance of educational support. So some people were receiving this from family members, some of them from friends, and some of them professionals. And the whole paper just kind of goes into detail around the different facilities and barriers and people's opinions and perspectives of these different strategies. So then moving on from there, I thought, well, it's great that we'll have these strategies in there, and the paper that I just shown there sort of helps to bring to light why something does and doesn't work. I then thought, okay, like let's try and understand those who are most at risk of digital exclusion, particularly the underserved groups, their views on their like health inequities and digital health inequities in general, and how their experience of using digital healthcare actually is. And then from there, getting their sort of unique perspectives on how they would like to be supported in the future. So I ended up interviewing 29 people. So it was interviews and focus groups even. So there was 18 people, I think, from memory across like 4 focus groups, and 11 of them were interviewed. They were all from the northeast. And particularly focused on this region just because of the high rates of health inequities and digital exclusion. So I thought, well, if I target this area, I'm going to get some really good insights. And all the different CLEARS groups that I presented before were represented across this sample. So I had a massive range of diversity within the sample. And then from these interviews and focus groups, I identified 4 key themes. And these themes just went into detail about people's experiences and how they would like to be supported in the future. So I'll just briefly go over these at the moment, just because I haven't really got much time, but I have got an abstract out at the moment, and we're busy writing up the actual full paper, so hopefully when that's out, it'll have a lot more detail. But one of the themes just went around people's challenges of accessing healthcare exclusively via digital means, and sometimes even like a booking system, there was no in-person way to book your appointment, so that was a challenge for a lot of people. We had things around the issues of using technology for healthcare purposes. So a lot of the time, some people had a lot of challenges actually logging into the NHS app because they didn't have photographic ID. So this could have been asylum seekers, and it could also be those who are on a low social income. So they don't have the money there to update their passport, or they don't have the money there to then spend on driving lessons to get a driving license, because sometimes it can be a bit funny with a provisional driving license. And then there's stuff around accessing educational support. So there was a few issues that got raised around here about relying on family and friends. So it can actually be like a growing sort of pond for domestic abuse. So some people who were in abusive relationships were saying that them having to rely on their husband to have support accessing the NHS app because they didn't have the digital literacy skills there to know how to do it themselves. It meant that they were basically providing someone else with more control over their healthcare in an abusive situation, so that wasn't really great. But then there was also saying that sort of support from professionals was a bit hit and miss. Like some people were really supportive, but then others didn't really seem trained enough in their eyes to actually be able to give them a response, because then themselves didn't know how to use the tech. And then the last one was around their perceived clinical usefulness of technology within a healthcare setting. So some people were saying, okay, like a video call, like a video consultation over COVID, it was amazing for them. because they could have a chat with a healthcare professional about some medication that they were recently on, and went through it and they thought it was amazing. While others thought that things like a video call wouldn't be good for a physical examination, and they thought that there needs to always be a place for an in-person discussion, because they think that just sort of helps them feel a bit more confident and reassured that the healthcare that they're receiving is high quality. They don't always be sat in front of a computer or on the phone all the time. They want that person to speak to them. So then, based off the findings from the systematic review and the qualitative study, we then worked with a company called More Than Minutes, and there was an artist there that was we worked together and sketched up a bit of like a poster for all the different recommendations I was currently pulling together. And then I sat down with some PPI members, some people who were in that qualitative study, and a gatekeeper who was a member of a community group, I think, who was in charge of that community group, and asked for their thoughts on a draft poster. After taking on all their feedback, we then refined it quite a bit, and it resulted in this pretty poster here. I don't know if you can see it too well with the teams, but there's loads of different ones. Some of them are centered for a particular group. It's like things around culture. We'll have things like all the information should be able to be provided in alternative languages, and we should be avoiding reinforcing stereotypes in any imagery and language that we use. But then there's some other stuff that's a bit more broad and can help a range of people, such as providing services and having policies to then back up and support the implementation of these services. So for example, some people were thinking that sort of devices and any sort of technologies that could be used within a healthcare setting should be regulated, like the price of them should be regulated, so then it's a bit more affordable for more people. And then after doing this kind of small little study, I then moved on to the last bit of qualitative research that I'd done. And then I went out and sort of interviewed 17 stakeholders. In this context, we particularly included anyone who had a professional role in either implementing like a digital health technology or a strategy within healthcare, or even providing a service to the community, so like a digital health inclusion class or digital skills development session within the community, anything along those kind of like lines. So we ended up getting quite a big range of different stakeholders involved in this study. So it included people from like healthcare professional backgrounds, including the ICB board. We had consultancy groups in there. We had people from the VCSE organisations, academia, health-related networks, public health agencies, a load of different people involved here. And then from the interviews I'd done, I then identified sort of 4 key themes that were coming out, and these were all related to the feasibility of implementing different digital inclusion strategies within healthcare. So one of them focused around the need for design principles, but then also the challenges of implementing them. So by design principles, I mean like making sure things are user-centered design at the very beginning, making sure you have a simple registration process, simple login process that you don't need any ID and stuff for. But then there's also the connotations about security problems and stuff. So that's all discussed in there. We'll have stuff around making sure it's digital first, not digital only, the design principles from the very beginning. Then there's also stuff around the need to build a supportive network across different organisations, because if you're giving out like something like devices and connectivity, it can be quite a lot of resources that you need. So not only is it to access those devices that you're going to give out, they need like cleaning, as in like the data needs removed from them, any repairs need to be repaired before they're given out to people, and all of that takes a lot of resource and a lot of time. So having the connections between different organisations really helped a lot of people, but can also be challenging to actually get those conversations started and get them going. Then there was a lot of things on the key considerations that need to be implemented when actually having these different strategies implemented within healthcare. So a lot of the stuff was coming around about the repurposing devices and the different things that a lot of people didn't realise was going to happen but then did happen, or like the time frames. As I was saying, like it can take a lot of time to actually repurpose a device, and sometimes your project just didn't really account for that time. So there was like different sort of practicality challenges we're coming across. There was a lot of issues coming across about support and connectivity. So if someone was giving out SIM cards, so say if they had 3 different SIM cards they were given out, so say it was from 3 or 2 and Vodafone, for example, those different SIM cards would work in a different way. So then the staff giving them out, it was quite a challenge for them to actually understand how these different ones work and get their head around that. And then there was also stuff around educational digital skill support and how that should be delivered like, in an informal manner, making sure it's tailored and all that kind of stuff, and the challenges that come around that. And the last one is actually adopting these strategies and pushing people and organisations to actually implement them and adopt them into practice. So some of the stuff was coming up how some organisations and some sort of people who are very high up don't actually recognise the need or the value of digital inclusion strategies. In their head, they think, well, everyone has a smartphone, and obviously that's not true. They sort of come from a different background to the people they're serving, and they don't really value it. So say if it was like a website design, they're not valuing keeping up that website design to make it inclusive, because they've got 10 other billion things that need doing that day that are a bit more high up in that importance. There's also a lot of concerns and pushback from organisations relating to the unintended harms of supporting digital inclusion. So if you're giving someone with mental health issues a phone that has internet connection, they could then sort of use that to then go on a gambling website, for example, and that would fuel the gambling addictions. So a lot of things were coming across that around the unintended harms and how they put things in place to overcome that. And then there's a few things around actually increasing awareness of the support available within different communities, because sometimes the professionals didn't know what was available within the community, and a lot of times the members of the community didn't know, like that they're served, didn't know as well. So then after I looked at all the different findings across all my work, so the 2 reviews, the scope and review, the systematic review, the 2 qualitative studies, the little validation study I'd done as well, I then looked into the wider literature to sort of further refine my recommendations and actually sort of identify the most important areas that I should be focusing on to recommend that we should be doing in the future, and try and form some like practical recommendations from the perspective of like researchers, healthcare professionals, healthcare decision makers, policy makers and tech developers. So I had like a breakdown of all these different recommendations, but what I'm going to just do is I'm going to focus on the sort of more healthcare professional kind of side of things, because I know that's probably a high quantity of the audience right now is probably from the healthcare professional background, but it's probably going to be applicable to a lot of other areas as well. So the first recommendation was raising awareness amongst professionals of the importance of EDI within digital healthcare. So this means that whenever you're developing like a digital inclusion strategy or implementing a new digital service, making sure you have got the perspectives of those different communities on board to begin with. So the way to actually practically implement this is to make sure healthcare decision makers don't implement something that's not been sort of validated, if you like, or had the perspectives of a variety of different groups who's actually going to be using this service on board before actually implementing it, because if the service is going to help them, they should actually see it as acceptable and move on that way. The second one is around identifying the different communities most in need of digital inclusion support within like the different regions within, say, the UK. So the way that this could be done is using that CLEARS framework and using publicly available data and also data from NHS trusts to identify the areas that these CLEARS groups are more likely to live. And then once you've got those sort of regional areas, more resources could be sent to those areas to then support those community educational classes or more devices, all that kind of stuff. Because you probably are more going to be likely to have some areas that are more well off and they probably don't need as much support as some other areas. And then the third one is around co-designing technologies and health services with underserved groups. So once you've got that sort of, say it's a software that you've developed, making sure people can actually use it. So say it's a security design system or log-on system that you're designing as part of, like, say, the NHS app or any other app, sitting down with a group of people and getting them to actually use it, so then they can pick apart the bits that they can't use, too complicated, needs further verification that people just don't have or they don't feel confident giving, and actually sitting down and using things with people before it gets implemented to make sure it's actually usable and not excluding anyone. And then the fourth one is embedding cross-organisational collaborations between different sectors. So then you get the perspectives from those sort of organisations that help in the different communities and have access to resources that one organisation just might not have. So by fostering collaborations between those organisations can really help sort of facilitate more holistic and more supportive service that you're developing. And then the fifth one is about providing individuals with the non-digital options to access healthcare. And this should really be enforced by a policy that mandates that a non-digital option should also be available alongside those digital options. Because yeah, digital services have their advantages, they're amazing, they're great. But if you don't have a smartphone, you don't have access to the internet, you don't feel confident using your smartphone, you don't have internet at home, then you miss out on all those benefits. So making sure that non-digital option is always there, that's to the standard of that digital option, will help include a lot more people, and you're not going to miss a lot of people in your healthcare service. And the next one is about providing or directing individuals to digital inclusion support services. So maybe having like a digital champion and forcing them a bit more, because they are a thing, they're just not implemented as well, or it's not recorded. Like always having a look to sort of see how many digital inclusion champions are out there, and there's not really like a good stat that's been released, and it's very vague about which sites do have them, which sites don't have them. So maybe having a bit more around that might help a little bit more, and making sure there's a bit of awareness of what's actually out there. And then the next one is around advertising digital inclusion support, using various methods. So for example, if you're having a consultation with a patient, you could just ask them, oh, how are you doing with the NHS app, how are you doing with this, do you need any support with it? And then once that sort of conversation starts, you can sort of then signpost them to say that digital inclusion support person within that site, that digital inclusion champion, or if you know yourself, because you've got a mate down the road who's delivering a kind of service, you can then sort of signpost them to that. But it's having that initial conversation, that initial advertisement of, okay, how's someone doing? Then sort of saying, okay, there's actually is support out there, because a lot of people just don't know that there is actually these support services out there. And then we should also start evaluating the digital inclusion support services, because at the moment sometimes the evaluation more just looks at how many devices someone's given out, but really it should be looking at the actual impact to different individuals. So is that service actually helping them to be digitally included within healthcare? How is that impacting their health? And also, who are we missing? So if you're in a certain area and you're getting a certain demographic through your door, looking at, okay, how can we then tap into this other demographic and make them aware of these different services that are available within that community, and evaluating it from a different perspective than what's already ongoing. And then looking at the future, we should start assessing and evaluating those recommendations that are pulled forward, to actually look if it's one feasible to put in practice, and 2, the impact they would make within like healthcare settings or within communities. And one way of doing this could be using the PEAS criteria, and one of the elements within the PEAS criteria is looking at like the economical impact. So for example, having 2 access routes to healthcare, a digital and non-digital access all the time, what's the economical impact that's going to have on the NHS, for example, and all the different things that go along with on the different recommendations. So actually assessing and evaluating the practicalities, the impact of those recommendations will be a really good next step to sort of see what we can do better. And then on that, I'd just like to thank all the participants who took the time out of the day to help with this big massive chunk of work, and then also my supervisors and co-authors for helping, and obviously you guys for listening. So thank you very much.
That was great, Sarah. You are running over slightly, so I can't ask too many questions. But I think for me, how do people reach out about those 4 themes and what can they do?
But the what? Sorry, I just cut out there.
So you've got your 4 themes and you've got your outputs and recommendations. How do the audience potentially utilise some of your research to be able to make a difference for themselves?
Yeah, so a lot more detail is in some of the publications that are already released out there. There's a few things that could be implemented easily, sort of just having a chat with someone. So say if you're a healthcare professional sitting down with someone as you're already in that consultation, probably takes an extra minute of your time just to ask them how they're doing with the technology. In the side of say VCSE organisation, you could be sort of connecting with other VCSE organisations within that area that you maybe know already, to sort of see how they might be able to support a service that you're delivering. So one might be able to give like digital inclusion, educational support, another might be able to give those resources, for example, and connecting with others and doing it that way.
Brilliant. And Violet's put up a couple of great comments in there, so you'll probably want to have just a read of those. Violet's always great. She's thinking of that patient, so we always like her contribution. But we will have you back. Please join us next time. So I'm just going to thank you very much, Sarah, by the way. I'm just going to very quickly wrap up the session today. Can you see that, everybody? That'll be a yes, I think. So just to mention that it is Get Online Week in October. So that'll run from the 20th to the 26th. The link is on there, so you can kind of find out more. Also wanted to just highlight that there's a health literacy community of practice that people may be involved in. They are running a session in October. I've put the link on there, but also have a futures site. So that might be of interest. So I just wanted to share that. I'd just like to thank all 4 speakers for joining us today. We've crammed a lot in. We have run over slightly due to the technical issues at the beginning, but we got them all sorted thanks to Leanne. And we will record and share the recording as well as PDF the presentation so that you've got a copy. Our next Digital Inclusion Forum, not as many speakers, and we're focusing on speech and language therapy with Mary Lander. We're going to give her a longer slot because she's hoping to bring a patient along as well. So we'll have a really great and interesting session. And then the second presenter is Sonia Townend from Ways to Wellness, and that's more around social prescribing, but they obviously see a lot of digitally excluded people as a result of that. So I'm just very keen for you to see that information, and please do register. The link is on there. Without further ado, thank you very much for attending today, and we will see you in November. Take care, everybody. Bye.